The relationship between time-restricted eating and cardiovascular outcomes, particularly blood pressure regulation, has generated considerable scientific interest and public speculation. 4-week randomized controlled trials employing isocaloric designs offer the cleanest window into whether meal timing itself influences vascular function when energy balance remains stable. These studies utilize 24-hour ambulatory blood pressure monitoring alongside endothelial function assessments through flow-mediated dilation protocols, creating comprehensive cardiovascular phenotyping independent of weight change confounders. Current evidence suggests that time-restricted eating without accompanying calorie reduction produces minimal effects on mean systolic or diastolic blood pressure across 24-hour monitoring periods. When participants consume identical caloric loads but compress eating into narrower windows, the expected blood pressure reductions observed in weight loss studies largely disappear. This finding underscores a critical distinction often obscured in popular discourse. Cardiovascular benefits attributed to intermittent fasting may derive predominantly from energy deficit rather than temporal eating patterns. Endothelial biomarkers, including circulating adhesion molecules and inflammatory cytokines, similarly show limited change when calories remain matched between intervention and control groups. Interestingly, some investigations detect alterations in circadian blood pressure patterns rather than absolute levels. Nocturnal dipping, the physiological decline in blood pressure during sleep, may shift in timing or magnitude when eating windows change dramatically. Participants who cease eating several hours before sleep sometimes exhibit modified nocturnal pressure profiles, though whether these changes confer clinical benefit remains uncertain. The mechanism likely involves shifts in autonomic nervous system activity and sleep architecture rather than direct vascular remodeling, as structural endothelial changes require sustained metabolic or hemodynamic alterations beyond what meal timing alone provides. These findings carry important implications for public health messaging. Individuals seeking blood pressure management through dietary modification should prioritize established interventions including sodium reduction, dietary patterns, weight management if indicated, and regular physical activity. Time-restricted eating may serve as a behavioral strategy facilitating calorie reduction for some individuals, thereby indirectly benefiting blood pressure through weight loss mechanisms. However, expecting meaningful blood pressure improvements from meal timing adjustments alone, without addressing total energy intake or body composition, appears unsupported by current controlled trial evidence. Future research might explore whether extended intervention periods or combination approaches yield additive effects, but present data counsel against overstating meal timing as a standalone cardiovascular intervention.